Hello everyone. We are now going to go over the peripheral blood flow cytometry from a 65-year-old man who presents with pancytopenia and numerous circulating blasts. Let's start with CD45 versus site scatter. You may want to remember that some labs use CD45 on the y-axis and they plot site scatter on the x-axis. So sometimes the plot may look a little reversed. Here in all the chapters in our book, we are going to see CD45 in the x-axis and site scatter in the y-axis. And the population that has the brightest CD45 and low site scatter, those are the lymphocytes, because lymphocytes, if you remember, they don't have much of cytoplasm and they have a very condensed chromatin in their nucleus. So there is not much complexity or granularity to account for site scatter. So they have the lowest site scatter and also they have the brightest CD45. And the gate that is just about the lymphocyte gate, that is the monocyte gate. And the monocytes, they have the similar intensity of CD45 expression like that of the lymphocytes, but they do have a slightly higher site scatter than lymphocytes because there are minimal granules in the monocytic cytoplasm. The granulocyte gate is the one that has the highest site scatter, and it includes granulocytes of all stages of maturation. Your promyelocytes, myelocytes, metamyelocytes, bands, mature neutrophils, and eosinophils can be seen in the granulocyte gate. And they have high site scatter because all granulocytes have a lot of granules in their cytoplasm. So that contributes to their site scatter. And also if you see as they mature, the nuclear complexity also increases. There is increased lobation, and that also contributes to the site scatter. And the blast gate is usually below the granulocyte gate, and the blast gate is defined by dim CD45, that is dimmer than the lymphocytes and monocytes, and they have low site scatter than the granulocytes because, again, blasts usually do not have much of granules, although some late myeloid blasts can have granules in their cytoplasm, and in that case, they do have slightly increased site scatter. But majority of the blasts, like the typical blasts that we see in most cases, do not have much of a granularity in the cytoplasm. And also it includes all types of blasts like monoblasts, lymphoid blasts. So all the blasts sit here. Along with blasts, there are a couple more cells that are usually seen in the blast gate. Those are the basophils and plasmacytoid dendritic cells. CD123 and HLA-DR can be used to kind of isolate those cells. And we'll see that in some chapters that we go over later. So now in this case, we see that this patient has numerous circulating blasts in the peripheral blood. So as expected, flow plot also shows a lot of cells in the blast gate, that is 75% of the cells. So these cells are gated red, and now we will follow through this blast population and we'll see what they express. So all the blasts are expressing CD34 and they have a partial CD33 expression. We call it partial because they are not homogeneously positive. That is, if they sit here, we'll call it homogeneously positive, but because they are only the subset is positive, we'll call it partial expression. But it is not like a distinct subset that is positive. It is the same continuous population. So the term partial is more appropriate to use here. And the blasts also express partial CD117. They are positive for HLA-DR. They're negative for CD15. They are partially positive for CD38. And they are homogeneously positive for CD13. They have a dim CD11B expression, partial dim. So far, if we see that they are expressing myeloid markers and immaturity markers. So CD34 is an immaturity marker, and they express myeloid markers 117, CD13, and partial CD33. DR is considered another immaturity marker, and 11B, I mean, it is just a partial dim expression. So 11B can be seen in both myeloid and monocytic lineage blasts. But it's a partial dim expression here. They're negative for the monocytic markers like CD64 and CD14. They're negative for CD56. CD56 is considered an aberrant marker in myeloid lineage blast, and it can be seen in leukemias arising from prior MDS, or in cases with 821 when there is KIT mutation. So all these things, there are some distinct entities that have association with CD56 expression, and usually CD56 expression is associated with poor prognosis. And one other use of CD56 is sometimes, in the bone marrow or in the peripheral blood, we don't see a large number of blasts. We only, especially in bone marrows, if we see a smaller number of blasts, and if they express CD56, we can distinctly say that these are, although the blast numbers are not increased, these are aberrant blasts. I mean, abnormal blasts with aberrant expression. So here in CD3 versus CD34, we see that the blasts are negative for CD3. So the CD3 that we see here is surface CD3. Negativity for surface CD3 can be seen even in T lymphoblasts. You have to keep that in mind. Cytoplasmic CD3 is needed if you are suspecting T lymphoblasts to eliminate, to rule out T ALL. So, but here we don't think it is T-ALL because it looks like it's only expressing myeloid markers so far, and also T lymphoblast always expresses CD7, and here CD7 is negative because CD7 is one of the earliest markers that appear in the progenitor cells that are committed to T lineage. Even in the pro-T cells that are in the bone marrow, CD7 expression is positive. So CD7 will be positive in T lymphoblasts. So here, if you're not suspecting that, you don't have to add your cytoplasmic CD3. Cytoplasmic CD3, some labs perform cytoplasmic CD3 and MPO, cytoplasmic MPO, and CD79A routinely, but most labs do not do them because those are cytoplasmic tubes. They just use the screen tubes with most common markers, and many leukemias can be phenotyped just by those tubes. And these add-on tubes are required for some cases where the screen tubes are ambiguous and you need to determine which lineage these blasts are definitely from. So that's when they add on those tubes that contain CD3, that is the cytoplasmic CD3, MPO, and 70. Here the blasts are also negative for CD2, CD8 is negative for might show up. Here we can say it is showing a partial dim expression. The blasts are negative for B cell markers 19, 20, and 10. So CD10 is commonly positive in B lymphoblasts, so that is also negative here. So this is a straightforward acute myeloid leukemia. So we have 75% blasts. Although we do not use flow cytometry to quantitate the number of blasts, we have to always rely on the differential count. If it is peripheral blood, your counts on the peripheral blood smear, or if it is bone marrow, your bone marrow aspirate counts. Those are the most reliable specimens to obtain your blast count. But because we see that in the history, they say there are numerous circulating blasts, and also we have 75% of the cells in the blast gate, we can say, we can top line our flow cytometry report here as acute myeloid leukemia. So now when coming to the report, when you report in flow cytometry, you will usually see a top line that says what is the diagnosis in many scenarios, or in some cases where flow cytometry is not the ideal modality to arrive at the final diagnosis, it will be more of a descriptive top line. Like, for example, let's say if it is a CML or if it is an MDS where flow cytometry alone is not enough to, for example, CML, flow cytometry is not flow cytometry is not enough for your final diagnosis. You need translocation 922. So in that case, you will just say left shifted myeloid maturation with aberrant blast or something like that. Here, it is a straightforward diagnosis that can be made from flow cytometry. So we can say acute myeloid leukemia, and you give the percentage of blast. And it is always necessary to write in your description what the blast express and what is the intensity of expression, because some of these are used for as targets for therapy. For example, CD33, you have antibodies to that that can be used for treatment. And some places, they also have clinical trials where the trials require the percentage of blasts that express these markers, individual markers, to see if the patient is eligible to be enrolled in that trial. And also we have antibodies for markers like CD123, for example. So some of these are used for prognosis, like for example, CD56. So it is always important to document what the blasts express. And if it is a partial expression, it's a good idea to give the percentage of blasts expressing that marker. And most labs usually have a table for that purpose. You'll see that in the final report, they don't write the percentage in the body of the report. It is usually seen in the table. And when you document these markers, the other utility is also because if the patient is coming back for follow-up after therapy, there may be a small number of blasts, that is less than 10,000 per cubic ml, that is when we use the term MRD, minimal residual disease. For evaluating MRD, flow is one of the recommended modality. And what they do is like they collect a large number of events, much more than what we collect for regular flow cytometry, and they try to see if there is a population of abnormal blasts. So now there is a problem here is we will also see regenerating blasts that are normal in the marrow. So to distinguish the normal blasts and from the neoplastic blasts, the prior phenotype always helps. One thing to remember is treatment can change the phenotype. Even when these cases relapse or if they are resistant to treatment, there may be variation in the phenotype. They don't have to be exactly the same. And also in minimal residual disease, the phenotype can be different. So two things that can help with MRD is one, to see if it is matching with the prior phenotype, then it's straightforward, it's easy. Two, if there is any aberrancy, any deviation from a normal myeloid blast that we can see in the bone marrow normally. So those are the two things that we use to evaluate the presence of disease in follow-ups. Thank you.